Hi friends, this is Dr. Shivakumar, Senior Interventional Cardiologist, Meenakshi Super Specialty Hospital, Madurai. With me, Dr. Balbir, Chairman, Max Group of Hospitals and Senior Interventional Cardiologist as well as electrophysiologist, who has traveled me all the way from Bangalore to do a workshop on orbital atherectomy. Together, we did wonderful cases today and just thought of sharing what is this concept called as orbital atherectomy, how it got shaped up in India. So we know that as elderly population in India is growing up, among them there is a diabetic population too, and there is a CKD. In those population, there is a tendency for calcium to deposit in the coronary arteries. When they get deposited, putting them on a stent on the calcium without properly expanding it will have a poor long-term results. Conventionally, we were treating these calcified coronary arteries with balloons, conventional balloons, and NC balloons, cutting balloons, scoring balloons. Basically, balloons, they just make the non-pliable calcium into a pliable, and we'll be deploying the stent. We are not very sure how much the stent got expanded. Whereas these atherectomy devices, particularly the orbital atherectomy, which is an FDA approved device, has been available in India since more than 1.5 years, and the big player, the Orbital, has got it for more than 1 year now. So these atherectomy devices not only making these calcific plaques pliable, they also reasonably remove the plaque. So we get a huge luminal gain just before the stent, and subsequently we deploy the stent and we may get the maximum expansion. This is how this atherectomy device got in a special place in treating patients with stenosed narrowed arteries. With this introduction, let me invite our friend today, Dr. Balbir, who is a chairman of Max Group of Hospitals from Delhi. He has a richest Indian experience now with orbital atherectomy, just to step it up the physics behind, the mechanisms behind, and more so about his Indian experience with this device. So to you, sir.
Thank you, Dr. Shiva. So first, I would like to thank you for inviting me to such a beautiful city and a beautiful hospital. So since morning, we've been doing cases, and we do 2 cases which had calcified lesions. And orbital atherectomy, I'll tell you about orbital. Let me first tell you that calcium is bad for the arteries. Why is it bad? Because it makes them hard. So once they are hard, when we inflate the stent, it doesn't expand fully. So we need artery which is more soft, and to make it softer, we have to have better tools than what were available. Orbital, by the name orbits around the artery, rotates around the artery in orbit, and tries to shave off the calcium. So basic purpose of this device is try to shave off the calcium so that the artery becomes pliable, more soft, and the stent can expand well. If the stent expands well, long-term problems are less. Like, for example, stent getting blocked again. Every one of us knows this is one of the biggest problems. The stent can get blocked again, and calcium is one of the biggest culprits to do it. Now with this device, we can make the artery much softer, much more pliable, so that we can get the stent in. So it has an advantage that it's a safe procedure, simple procedure, not so difficult to do, does an atherectomy, cuts out and shaves the calcium, so that you can get in with your stent and expand it well and give a patient a very good long-term outcome. So this is what I think in a basic nutshell what orbital atherectomy does.
Fantastic, Dr. Balbir, sir. And earlier we were having a rotational atherectomy. It's a kind of diamond coated burr. Unlike orbital, the diamonds were coated only in the front. You can only ablate the calcium during the front run, not during the back run. So it was kind of a drilling device. The sizes of the burrs were available ranging from 1.25 to 2.05 plus. We need to upgrade the guide catheters, inviting more complications, all kind of stuff. How this orbital atherectomy differs from rotational atherectomy, sir?
So there are a lot of advances in orbital atherectomy. First, the bulkiness has gone. The whole system is very neat, clean. Doesn't need any gas to run the burr. In a rota, you need a big helium cylinder to run the burr. Here, you don't need anything. It's very, very simple to do. And the most important thing about this is that it also has a coating with diamonds, but it rotates around the vessel. Rota does not rotate. Rota just moves at a speed, fast speed forwards. It can't do the burring and the backward direction. Since orbital has diamonds all over the place and it orbits, it can cut while it's coming back. So which is a big advantage, that your burr cannot get stuck, rota can get stuck. Your simple procedure can get very complicated if your burr is stuck. It's a nightmare. I really tell you, it's such a nightmare to have a burr which is stuck. So it has some very basic advantages over rota, and it's clearly an advance over rota ablation.
Fantastic, sir. Earlier, I was mentioning about inadequacies of balloon-based preparation of a calcified artery, particularly when you misjudge the calcium within the vessel, in terms of ill preparation, in terms of inadequate expansion of the stent. And more so, with rotational atherectomy, particularly the patient needs to have a temporary pacemaker. As the burr size goes up, there is a more thermal injury. The amount of particles generated by rotational atherectomy with a higher size burr may be more, and we are running a risk of abrupt vessel closure, and in a particularly hemodynamically compromised patient, these slow flows can further worsen the scenario. In this background, can you establish how orbital atherectomy is a safe tool as well as the efficacious tool, sir?
So, in my experience, we have not had any patient where the flow got compromised or the blood pressure reduced. We had to use some other support to increase the blood pressure. It's never happened. The pacemaker requirement with during this procedure is very low, which was the reverse with rota. With rota, we used to be prepared with inotropes that we may have to push some blood, may have to increase the blood pressure by pushing some inotropes, have to have a pacing support always in hand. These things don't happen with the orbital, because the particles that of the calcium are so fine that they are cut, that they don't block the artery down on the distal course, and this advantage is seen worldwide and is also seen in my experience.
Fantastic, dear friends. To sum up, orbital atherectomy from the big player Abbott is a new tool, calcium breaking tool, available to India for more than 2 years now, and it has a lot of advantages over the balloon based preparation of calcium, and a lot of safety more than with rotational atherectomy based calcium preparation. And with this sum up from my side, I'll just ask Dr. Balbir to come up with the richest Indian experience which he has to enlighten us how the Indian patients responds to this OAD device against the Western population.
Right. So I think the Indian patients need it much more than the Western population. We have very high incidence of diabetes. We have much higher calcific disease than the seen in the West. Our need for this device will be much more. We have lesions which are so tight that cannot be crossed with the balloon. So all these make it a very, very attractive agent, and with an FDA approval, with device having been used in multiple millions of patients already, and with some good Indian experience, I think we have a much brighter future in interventional cardiology with these new developments that are happening.
Thank you, one and all, dear friends, for having connected with us today. Thank you, one and all.